Okay, so maybe we can have the open house session now. I had some questions trying to read what goes on in the student's mind. So maybe I'll put those questions. Harindra is not there, but I think two of you can take, and some answers Dr. Anurag also can. My first question is, do we go by the clinical condition of the patient, which means whether the patient has hemodynamic instability, features of sepsis, counts, CRP, ABG, which would indicate the severity of the injury and also whether there is a perforation, or is it that in every case we have to do an endoscopy and or a CT scan? So to elaborate, suppose the patient took the ingested the corrosive, say 2 days or 3 days ago. Patient today comes to us, is otherwise all right. She says that I have been drinking also and I have no problem. So most likely this patient has a minor or a low grade injury. So do we still need to do endoscopy and CT? On the other hand, there is a patient who is obviously sick, looks in sepsis, has severe pain either in the medial chest or in the abdomen, has the clinical features of a perforation, or a plain X-ray shows some extra luminal air. So do we still need to do endoscopy and CT? What is the opinion?
Can I answer this question?
Yes, please.
Yeah. See, in fact, a patient who is sick, there is no doubt, who shows clear-cut evidence of perforation or mediastinitis. I don't think he needs endoscopy. He needs surgical exploration. So there is no role of doing endoscopy in such a patient. In the first scenario where you have been telling that the patient 2-3 days coming and he or she is eating and drinking everything, I think it is still imperative to do a endoscopic assessment and grade the injuries, because it has been seen that up to 12 to 15% of the patients who are asymptomatic at presentation can go on to develop stricture. So it is important to grade the injuries in all the patients.
Okay. The second question, maybe Harindra covered it, but because I was not well connected, I could not hear his entire presentation. In a patient with acute corrosive injury who comes, say, within first 24 hours or so, the injury to the respiratory tract is more important than the digestive tract, because that can be life-threatening. So what evaluation a student or a practicing surgeon should do to evaluate that? What are the alarm signs which indicate that we should immediately get the help of an anesthetist who can either intubate, or a surgeon who can do a tracheostomy if it is required? So what are the alarm signs of a respiratory injury?
Yeah, I think it is stridor, hoarseness, and difficulty in breathing. Because whatever the situation is, whenever there is corrosive ingestion, some of the fumes, they tend to go to the trachea and airway only, so they can cause some amount of edema. So it is the edema which is usually obstructing in the initial part, and subsequently, if some corrosive is ingested, that can lead to some tracheal necrosis or bronchial necrosis. That is a later event, but immediate it will be edema. And if a patient is breathing well, he or she is not tachypneic, and saturation is maintained, we need to observe them closely. And if a patient develop any of these signs, it's better to do intubations, and all the intubations has to be done under guidance. No blind intubation should be done, because blind intubation, missing the larynx and going into the pharynx, can potentially cause perforations and complicate the issue. So if there is a difficulty in finding the lumen, even under endoscopic guidance, it is better to go in and do a early tracheostomy rather than making another attempt to do the intubation.
In fact, this underlines the importance of local examination of the inlet.
So yes, I think apart from that, the situation could be either very obvious, that the patient is having aspistic symptoms, stridors, etc., and just put a pulse ox. Either it looks blue, or put a pulse ox, you can see what is the saturation. But more than that is the examination. Means sometimes these are actually not so aspistic. The saturation could be just plus minus, but you examine the mouth and the larynx, and we find a severe burn. Sooner or later, these patients are going to have a problem. So watch watching masterly inactivity as well as watching them very carefully and continuously is very important. And Ajay says we should have a very low threshold of doing a tracheostomy in these patients.
I remember that before the role of CT came in a few years ago, it was only endoscopy which was the investigation. And I always used to tell the students as well as practicing doctors that unless you have a highly experienced endoscopist like Dr. Anurag, one should probably not attempt an endoscopy in these patients because if it is done by an inexperienced endoscopist who hasn't handled a corrosive injured esophagus earlier, who is not aware of the precautions which need to be taken and the softness with which endoscopy is to be done, it sometimes can cause more damage because endoscopy is mainly to assess the severity which decides the degree of management. And as was mentioned yesterday, or maybe by Das today, that all this also has a background of the insurance cover, which is the US practice of medicine. And therefore, today, when there is a role for a CT scan, also as was highlighted yesterday, that first a plain X ray chest and abdomen, then a non contrast CT, then a CT with IV contrast, and then an oral contrast CT. Because CT is available at most centers, but help of an expert endoscopist and experienced endoscopist may not be available at every place. So, what is your opinion that if you are not sure about the skill of your endoscopy colleague, whether CT should be the first investigation after plain X-rays and you should reserve endoscopy for later evaluation as and when stricture forms? Maybe Dr. Anurag can comment on that first and then one of the surgeons can.
So I don't deny two things here. One is that you have to have a very experienced endoscopist doing the endoscopy. The need for endoscopy is not debated any longer. It was at one point of time, but today the need is not debated because the type 1 and the type 3B kinds, the two extremes, if you find, the management changes. One is a early discharge and second is maybe a preemptive, surgery or you being ready for the immediate emergencies. So one is yes, a very experienced endoscopist has to do it very gently, low insufflation, and they should know where to stop. That's most important. So even if I start doing an endoscopy, if I don't know where to stop and I have to do the full endoscopy, then I could go wrong so many times. So that's one part of it. And the second part is when to do a CT if you're not doing an endoscopy. I would say largely it's the clinical condition of the patient that will then decide whether we do a CT or we don't do a CT, because it is only the clinical condition which will tell us what to do. Finding a chance perforation is very unlikely. And so the CT is very, very unlikely to change the course of illness, will really not help much. I would personally not do it if the endoscopy is not being done. I don't know what the other panelists would have to say to that.
Besides the information obtained from endoscopy, you will not get it on CECT scan. CECT scan at the most will tell you the thickness and whether there is circumferential involvement in the length. But the exact morphological picture, you will not get it on CECT scan.
True.
No. In fact, as per the CT grading, if it is grade 3 injury, I mean, I am not contesting on the role of endoscopy is a must, but CT can be adjunctive, particularly in high grade injury when we see grade 3 injury or grade 4 injury, where we can see non-enhancement of the gastric wall or non-enhancement of the esophageal wall after giving IV contrast. Then it becomes an indication of doing a early intervention and early surgery in these patients.
So Vikas,
So
as you
CT
said, it's an adjunct.
Yeah, it's an adjunct.
Yeah.
I don't contest on that. Yeah.
So for the benefit of Das, you want to say something, please? Yes, Das, please go ahead. आप muted हो, unmute कर लो.
Yes, I have. My observation is, rather, our departmental observation is, we usually get two groups of patients. One who come really hemodynamically unstable, and in those patients, they are in a state of shock. And in those patients, you have no time to, they are not fit for CT scan or any other intervention, and they are also not fit for surgery. So we have never been able to take them for surgery if they are really unstable. Now, in those cases, even a simple chest X-ray and abdominal X-ray, if it is suggestive of frank necrosis or gangrene, so we take those patients straight away for surgery whenever they are fit for surgery. If they become stable over a period of 24 to 48 hours, and then the question comes whether you should do a endoscopy in these patients or not. Now, in many forum, I have witnessed the people say that if you really do, particularly I've heard Dr. Anantakrishnan saying that he is not he doesn't do endoscopy within 48 hours or 72 hours. He used to do it after 7 days, and he believes in doing a re-endoscopy after second week or so. Now, my question is whether we can actually, what are the those group of patients where we can really avoid doing a endoscopy. Like for example, a patient who has taken 20 ml of acid and immediately he throws out and comes to you with burning chest pain or so. So particularly in our just in front of AIIMS, there is Safdarjung Hospital. A lot of patients come there, go there for with this type of injuries, and about maybe 70% of them, and more than that, they would be just managing 1 or 2 days with IV fluids, then start orally just on the basis of history and the examination, and then on third day or so they would start orally water and so, and then they would definitely discharge the patient. So is there a case like that, Dr. Anurag?
I will go back to what my initial statement was. Again, I'll repeat that. Suppose there is a patient who swallowed some corrosive 2 3 days ago, and the patient today, after 2 3 days of the corrosive intake, is hemodynamically and septically stable. There are no features of instability. And she says that she has been taking liquids. What usually practitioners will advise: take cold fluids, take cold milk. And she says she has been doing that, and she's otherwise all right. Do we still do an endoscopy, or we wait and see what happens? So this is one group. Can we avoid an endoscopy, Dr. Anurag?
Yes, sir. Clinically, I would agree totally. I mean, not that all 100% should always undergo an endoscopy. The ones who you get in history of maybe a very small swallow, or having, spit it out as soon as they realize that this was an acid, and who are absolutely and totally clinically stable, do not need an endoscopy. And I would personally not always do an endoscopy. The timing, at least in our department, we tend to do it within, if we have to, within 48 hours. I'm extending the answer to this question is because I want to bring in a point where Sir mentioned that there are some who want to do it at 5 days and even up to 10 days. Now, there are two aspects of wanting to do an endoscopy after 48 to 72 hours. One is, of course, to grade the severity better. And second uh, is it safe to do it at that point of time? And third is there a therapeutic benefit there and then while you're doing an endoscopy? So, two or three reasons to do the endoscopy at a later date are, of course, grading it better. The risk of doing endoscopy after 72 hours is, I think, again, as you mentioned, if you have an experienced endoscopist, really there is not so much of a risk. People have gone to the extent of doing endoscopies from between 10 days to 15 days and much before the end of 3 weeks, and actually dissecting the synechiae which form between walls so as to try and decrease the incidence of strictures at a later date. So here you have such aggressive endoscopists who are trying to dissect of course you have to do it absolutely and totally carefully, but you have aggressive endoscopists who kind of, are partially dilating it by cutting the synechiae. So safety is not an issue. You can grade it better by doing it later also, no doubt about that. And then there are times when they come with those sentinel bleeds or they come with definite or at least partially suggesting complications in form of fistulas, large fistulas, that you just might want to do an endoscopy at a later date. So not for all. Yes, there could be some incidences where you would not do it, clinically unstable or very stable. And the timing, we don't have to stick to it that real bad. I think yes, if you do it around 3, 4, 5 days, of course we don't do it. We do it in the first 48 hours. But I've learned at least from so many people that it's safe doing it at a later date also.
And the second part of the question, again for the students, is that now, because these are two key investigations in a patient with acute corrosive injury, is the CT to be done in all patients? If not, then in which patients it is not required, and in which patients it must be done?
So wherever it is clinically indicated, not for all for sure. So clinically indicated means unstable patients, you're suspecting a complication. And like sir just mentioned, if the patient is very unstable, at least the endoscopy has shown grade 4 changes, and you want to find out what the stomach status is like, which need not necessarily be seen on an endoscopy because you wouldn't inflate the stomach as much as you would want to. So those would form some indications for doing an early CT. That's what I would also personally do.
And would you agree with what was mentioned yesterday, that first you do a plain CT to look for free air, then you do an IV contrast CT, and then if you suspect a perforation, you do an oral contrast CT, so in 3 parts?
So that can be done there and then on the table. So there is really no harm in trying to follow that protocol. These are sick patients, they could well have renal compromise. So any added one procedure and second expenditure is worth saving. So, but when we do it, we give the oral contrast, and we also give the IV contrast in the same go if the patient has no renal compromise. We usually don't follow the protocol of doing just a non-contrast first, and because if there is perforation and if there is contrast spill, it doesn't really deteriorate the patient. And so we personally don't follow it in 3 stages. But if someone is doing it and is being extra cautious, I can't say why you're doing it. So
Vikas,
we don't
yes.
depart to that.
But I think we always prefer to do a non-contrast CT first and rule out any pneumomediastinum or pneumoperitoneum, because howsoever sometimes a small perforation can lead to a small pocket of air which is not picked up on routine radiograph. And then once it is ruled out, then we can give oral and IV contrast both.
Absolutely well taken, sir.
Yeah.
Absolutely well taken.
I think, in my opinion, when a patient is admitted, means someday, somewhere down the line, he would need a CT scan. But it's a matter of timing when you should do it. If he's stable patient and injury is of higher grade, or clinically we are plus minus in suspecting whether he has a chest, he has a mediastinitis, he has a peritonitis, we are not very sure, mild tenderness here and there, then it's worth that rather than doing 3 CTs, we wait and watch the clinical signs. If they're not deteriorating, maybe after 72 hours or so, we can have a CT scan. That's a matter of debate. That's what I'm saying. So we use only one CT scan, and most of the time, because of the oral injuries, oropharyngeal injuries, or the pharyngolarynx injuries, they are unable to drink the contrast, swallow the contrast. So that's why we do non-contrast in all of the cases as the first step.
There are 3 questions on the YouTube which have come to me.
Yes.
I will read them out. Dr. Ankit Sharma wants to ask Dr. Chetan, do you not use gastric conduit at all? Or if you use it selectively, then when do you use stomach in preference to colon?
We never use gastric conduit. We always use colonic conduit.
Is there a situation where colon may not be suitable?
No, sir. As a rule, we always do a colonoscopy for all our patients prior to doing that, though it is not a must, but it's a protocol. So if there is a diverticulitis or if there is some disease, then we would defer using it. But otherwise, as a rule, we always use colonic conduit.
And sorry, I missed some part of your presentation in between. Do you do a colonic angiography also?
No, sir, we don't do a colonic angiography unless the patient is means there is a pre-disease, that is, he's suffering from coronary disease or is atherosclerotic. Only in these group of patients we would do it.
But most of these patients are usually young
Young
patients.
patients, yes.
Then Khalid Durrani wants to ask, has a comment, maybe you can respond. Another indication for surgery would be perforation on dilatation when endoscopic stent is not available.
Yes,
Would you-
that is the indication. That is one of the indication, but it's not an elective indication. It's an emergency indication. In that case, you would do it. Again, the same thing, depending upon where the site of perforation is, you plan your surgery accordingly.
But
In, in fact,
for an endoscopy induced perforation, I mean, from exam point of view, the treatment of choice would be stent.
Yes, that is
Not
one of the indications where you should definitely use a stent. Self-expanding metallic
covered.
stent will be very useful.
In that case, we need to use a covered metallic stent.
yes.
And secondly, I mean, regarding this query about perforation in the setting of corrosive, sometimes there can be anecdotes. I mean, this can be exception to the situation. You need to observe the patient closely because of the lot of fibrosis laid around the esophagus. Sometimes these perforation can be very well contained in the fibrosis itself. If the patient is not clinically deteriorating, there is a case for managing these perforations conservatively as well.
So, Dr. Anurag, what would you do? Suppose you're doing endoscopy and you have recognized during endoscopy or say afterwards that there is a perforation. What is your approach?
So if we detect a perforation there and then on the table, we would always stent the patient. I don't say that all would not heal by themselves or with conservative treatment, but you can't actually predict the ones who will get into localized collections and sepsis. And that chance should actually not be taken, because if you delay the stenting, then things become very troublesome. One, it makes it more difficult for the surgeon to handle the patient, and of course, the general condition can rapidly deteriorate. So, I would say if you detected an endoscopy on the table, always stent the patient and not wait for a conservative trial. Yes, if you get to know about the perforation a day or two later, that is when a CT scan will tell you what would be the best approach.
I think when Vikas said
And
observation,
also,
probably this was the subgroup that already 24 or 48 hours have passed, patient is otherwise stable. Maybe you can show whether it has already closed or
Yeah,
continued.
yeah, yeah.
Last wanted to.
and I, of course, that is the end of the road. I believe that's the end of the road for further dilatation. Or Dr. Anurag, is it possible that, so suppose there is a contained perforation, it has healed, is there any scope of further dilatation, or they are 100% surgical patients?
Sir, a previous perforation is almost, I wouldn't say it's an absolute contraindication, but is a contraindication for future dilatations.
By and large.
Take a colliery from, say, eclasia. You do get patients who have had a perforation, a very, very minor leak, which healed on conservative treatment, and who was earlier. Now, of course, we would go for poem or something of the same sort, but they were dilated even after a history of perforation in the past. But I would treat it as an almost an absolute
I
contraindication.
think for the students, a perforation
Absolutely.
would be a contraindication for dilatation.
Yes, sir.
A corollary to that, what are other contraindications for dilatation in a corrosive stricture?
Sir, if we have a deeply ulcerated esophagus at the end of 3 to 4 weeks, I would not dilate then and wait for a while, wait for at least another 2 weeks, of course, not beyond 8 weeks, because then dilating the esophagus becomes more and more difficult. The strictures become very tough. But that's really not a contraindication, you're just delaying it. Second is suspected. You have those, like I mentioned yesterday. So we had this patient who had some sentinel bleed during the acute phase, and we dilated the esophagus 4 weeks later once, and even before the patient was taken up for a second dilatation, that patient presented to the emergency with a massive bleed and died. So, if there are sentinel bleeds and a CT scan suggests a very thin rim between the wall and a major vessel, I would say not to dilate that patient. Third is a very thinned out large diverticula. Yes, it can be dilated, but with great caution. You have to be very sure about what you're doing. The dilator should not buckle above the stricture, because if the dilator buckles, it's going to go through the diverticle. So these two or three things would always prevent me from dilating these patients. We've had just one patient. I don't know if the other panelists might tell us more on that. Is one patient who used to go into stridor because of the dilatation. So as soon as you start dilating, and the patient used to go into stridor. So we did that twice, and then subsequently we never dilated the patient, and that was because of stenosis on both sides. And once you're dilating the esophagus, it's compromising the already compromised tracheal lumen. So that then also forms a contraindication to future dilatations.
Harshil Shah is my student. He wants to ask you, Dr. Anurag, that for an established stricture, other than a complication or an emergency, uh, what is the definitive point for reference for surgery after you have tried either dilatation or stent?
Sir, a definitive point for surgery would be a failed dilatation. Now, here is where the definitions don't apply. So I would not go by the definition of a refractory or a recurrent stricture. I would rather go by what Dr. Brewer had to say in his study in gut, that these patients tend to go low on a dilatation protocol after 1 year, and after 3 years, it takes you 3 years for them to get to the protocol followed for a GERD stricture. So I would continue to dilate patients even if it is up to that much number of years, if the patient one can afford it, and second, if I am able to at least go up to 14 or 15 minimum over subsequent dilatations. If I'm just not able to go over 10, 11 after having done 5, 6, 7 dilatations, I would go on to use either intralesional steroids or mitomycin. See, mitomycin we don't use. I mean, out of habit we use steroids. And like I said, I used the electrocision only once. So those would be the indications to go on to shift to a higher grade of treatment. I have personally used a stent in corrosive just once. Again, either because now less and less patients with corrosive come to private hospitals, so we don't get that many patients. And our aggressive dilatation protocol really doesn't 10% refractory, you do get everywhere. But I don't have a very large experience of using stents, though I can just say what the literature says. But my own the experience of using a stent is just one, and the patient did very well. But yes, if the patient doesn't respond to even a stent, and you have to take that stent out after 3 months, and the patient gets into a stricture again, rather than putting a stent again, I would send the patient for surgery. So, not being able to dilate over multiple sessions, not being able to reach 13, 14, that's one thing. And second is a stent which doesn't help. That would be the end point for me.
An extension to the same question from Harshil again is that suppose we are dealing with a refractory or a recurrent stricture, and now we are waiting for, I mean, that we have decided that surgery is to be done, but we are waiting for the maturation of stricture, which I think is about 6 months, or the patient's nutritional status is poor and we are waiting for nutrition to improve. So while waiting, do we continue to dilate?
No, sir. I mean, if we've already decided the patient will definitely go for a surgery at the end of 6 months, and we have a feeding tube in place, I would stop dilating the patient. Why risk the perforation for such a patient and make the chances of surgery even worse? Because if you have the nutritional standby in place, and you are sure about dilating, I am not very sure how one would be very sure about dilating it after, I mean, taking off the surgery after 6 months. But if yes, something in the patient tells you that you should stop dilatation, we stop dilatation. It will not serve any clinical purpose at all.
I think we finished with the online questions. Any of the experts would like to make any comment, any question to
Yeah.
each other?
In fact, a couple of technical questions with your permission, can I ask?
Yes, please. Go ahead.
Yeah. So, question, to Dr. Chetan. So, first of all, you have advocated doing a end-to-end esophagocoloplasty. So, how do you deal with the lumen mismatch between the esophagus and the colon? And secondly, again, corollary to this question, that once you are dividing the native esophagus in the neck, so how will you be able to do the surveillance of the esophagus, which is native esophagus, which is left in the body?
Correct. So coming to your first question is end-to-end anastomosis. I am not advocating end-to-end anastomosis.
No. Yeah.
So in case if the lumen, there is no mismatch in the lumen, then we would like to do an end-to-end. Otherwise,
Okay.
we do side-to-side anastomosis.
Yeah, because what our practice was, again, putting the end of esophagus on the anterior or posterior wall of the colon. Yeah.
So, yes.
Yeah.
And as far as surveillance is concerned, means basically these patients, what we do is we have a good follow-up of these patients.
Okay.
So basically on symptomatology, that
Okay.
once you feel that is when you would investigate this patient, rule out malignancy.
And you transact the esophagus in the abdomen also, or you keep the esophagus in continuity in the abdomen?
We keep the esophagus in.
Yeah, because we had one patient where the esophagus was transected. He came on follow-up and he was forming a esophagocele.
Yes.
And every 10-15 days, he will have some discharge and pleural effusion that will seal off of its own. So that problem can come, although it is said that because of squamous lining, there will not be any secretions on the esophagus, but we can get some esophagocele kind of a thing. Because what we have been doing, we have been advocating doing a esophagectomy and gastrectomy if required in these corrosive injuries. Yeah, because we don't because what we feel is, choosing the posterior mediastinal route is a more physiological, and you don't need to do sternotomy and dilatation because the colon goes up very easily through the posterior mediastinal route. And another interesting thing.
Let me take the student's question first before time runs out.
Please.
Dr. Ankit Sharma wants to know from Dr. Chetan that suppose there is a single long esophageal stricture refractory to dilatation, why not gastric conduit?
Again, because usually these patients are young, they have a huge problem with gastroesophageal reflux, which may again lead to ulcerations and a theoretical possibility of malignancy developing because of the continuous reflux. And their quality of life is greatly affected. So colonic conduit is always preferred over a gastric conduit.
Okay, Vikas, please carry on.
Yeah. Second, another interesting thing that Dr. Chetan, you have mentioned that doing a colojejunal in case the gastrectomy is required. So, but what we have been doing in our practice, particularly, is we have been doing a coloduodenal anastomosis in case gastrectomy is required, because invariably in these patients the stricture is juxtapyloric, and because of juxtapyloric and pylorus, and first part of duodenum is usually normal. And we preserve the intraperitoneal part of the duodenum, and then we do this thing coloduodenal. And when you are using jejunum, you are using it as a loop jejunal loop anastomosis, or you making a separate Roux-en-Y loop?
Separate Roux-en-Y.
Separate. So that means you are adding one more anastomosis. Yeah.
Yes.
Yeah.
So Chetan, suppose we are using right colon, will it be a esophagocolic anastomosis or will it be an esophagoileal anastomosis preserving the ileocecal valve?
So we are generally using left-sided. Very rarely we have used right-sided, but in that case it becomes a esophagoileal. A small portion of the ileum is kept behind, so the advantage of the ileocecal valve is maintained.
Yes.
Yeah, we have 4 more minutes. Yes.
Yeah, please. Okay. And another interesting query. When you are using left colon based on ascending branch of left colic artery, and you are using isoperistaltic or you are using antiperistaltic loop colon?
We use isoperistaltic.
Yeah,
Having said that, actually it's a conduit. It doesn't matter whether you use a isoperistaltic or
no,
antiperistaltic.
that is okay, but because there are two ways of doing it. Because based on the ascending branch, you can take the descending colon and sigmoid in the neck. Another way is to take the transverse colon and ascending colon in the neck. So that becomes iso and anti. That is what my contention was asking. So because what we have been using is taking the transverse colon and ascending colon in the neck, basing on the ascending branch of left colic artery.
So you all use the right side,
Yeah, we will use transverse colon and the beyond
ascending
that
colon.
clutcher. Yes, yes, yes.
Any other? Yes, Das, any specific
So,
points?
I have two questions, but first I will start with Dr. Anurag. Uh, how long we go on? This is a question put to me by my students many a times in the rounds. How far and how long we go on dilating these people?
So if I
What is the longest follow-up that we are having? Patients surviving on dilatation only.
So, if I am allowed to quote my DM days, then we've had patients coming for at least 7, 8 years for dilatation. But here, as of now, I still have one patient who's been coming to me beyond 2 years for dilatation. What happens is, I mean, my own cutoff would be not being able to go up to 14 also. So if I can go up to 14 millimeters, I tell my patients that you have to now come back as soon as you get the first sign of dysphagia so that I can start dilating you all over again early. But if I'm not able to go up to 14, I would not go on for years together.
So are there cases who are really were going on dilating for last 20 years, 30 years because they're adolescent and adults. They will live for 40 or more than maybe up to 60, 70 years. So how long we can go on dilating? Is there any really long-term study to say that after 30 years also with dilatation they can survive and have a good quality of life?
I cannot quote a study, sir, but I can all I can say is that uh, can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
All I can say is that if there is a patient who comes back to you maybe at 15 years or 20 years with a fair interval of no dilatation, there would be no reason not to dilate this patient. So, but I can't quote you, I cannot give you hard data to support what I'm trying to
Okay,
say.
but if we believe Dr. Nishad, then we should not be dilating any one of them.
After 20 years of that, so you have to do
There
some of
is a definite risk
that.
of malignancy.
Yes, sir. I mean, one has to obviously screen them and screen them well. I mean, we don't follow a screening protocol, at least here in India, because they don't come back. I mean, if we go by the literature there, we have to start screening after 15 years of the corrosive intake and keep doing it.
Exactly, I was going to ask that screening protocol.
Yeah, so screening protocol would be after 15 years of corrosive, it starts after 15 years and every 2 to 3 years. But I don't think I've ever done it in any patient. I mean, they don't come back. And but yes, if they come back after a long period of no dysphagia, first thing to do would be, of course, to rule out a malignancy. And if you can rule out a malignancy with high definition scopes with NBI and taking directed biopsies, you can be reasonably certain that you're not missing out on an early malignancy. But yes, if you're not certain on missing out on an early malignancy, then of course it will not be. That will be the end of dilatation and surgery.
And
So we are at
and last but
9:30.
not the least,
Yeah.
sir.
Any concluding remarks from Das and Vikas? We have to finish.
So, so
Yeah.
before that, interestingly, I think I guess Dr. Ankit Sharma, who is asking questions time and again about the gastric pull-up, is one of our MCA students. I think he is asking that because he is seeing us doing gastric pull-up in many cases, wherein the cervical esophagus is fine. What I used to do is after dividing the esophagus down below at the G junction, I make a small hole. We need to do pyloric stretching. At the same time, I do a scopy and see what is the mucosa status of the stomach. It looks reasonably well. I lift up the stomach. Now, regarding the reflux part, it's well described in the literature. You can cover these people. They are not always having reflux all the time. It is just like you do a coloduodenostomy. We did four cases of coloduodenostomy. All of them had refluxes. Unfortunately, I don't know why. And then we have to change to colojejunar anastomosis 1Y. Similarly, we have never seen very really troublesome refluxes in these patients who have stomach pull-up. But at least when you do a stomach pull-up, we are sure that we have a backup. If that gets strictured, we have a colon to deal with. And same thing, we also we need to discuss some point of other sometime that what happens to the restrictures. That should be that was my last question. What happens to the restrictures? We got not enough literature on this. So Dr. Chetan, if you can conclude by saying that.
So as far as restrictures are concerned, we keep these patients on regular follow-up post-surgery, and we do their periodic endoscopy and confirm that it remains patent. Another important thing I wanted to point it out, especially to Dr. Govil, is what we do is following a successful endoscopic dilatation, we teach this patient self-buginage, and we ask them to do that at home and come to us periodically at the end of 3 months initially, then 6 months. And that is how we ensure that they remain dilated.
Sure, that's right, sir.
I think we need to, because we are already 3 minutes beyond 9. We follow strictly starting at 7 and finishing at 9. So I must thank Das and Vikas, who very readily agreed to moderate this session. Thanks to all the speakers, Dr. Anurag, Dr. Chetan, and yesterday's speakers. But special thanks to Nishat and Harindra, who are the young faculty for the masterclass so far. I have been approaching all the senior colleagues, but this time I thought I will ask young faculty also to come in, because this is how they will get trained in making presentations. And I hope they don't mind if we make them some comments and some suggestions, of course, privately, not in public. And thank you. And I must add that all the technical support for all the activities of JST and masterclasses and Jaipur Surgical Festival are provided by Dwarika Clinic, which is owned by my former fellow from SGPGI, Dr. Avinash Tank, and his team, Himanshi and Pinesh. Himanshi, if you are there, would you like to come in?
Yes, sir.
Keep your video also on camera if you want, if you can, so that everyone can see you. And we would like to thank you and Pinesh for all your help. Oh, both of you are there. Good, good. Thank you. Thank you very much. Thank you. Thank you. Thank you, everyone. Good night.
Thank you, sir.
And we will have the next masterclass on the last week of January. Thank you.
Thank you very much.
Thank you, sir.
Good night.
Thank you very much.